Good day. I would like to take this opportunity to congratulate Diabetes Philippines for their scientific annual convention. I would like to thank the organizers for having me. I am Maria Fea Nes Gomez. I am a fellow of the Philippine College of Physicians and a fellow of the Philippine Society of Nephrology. For today, we will be discussing the practical approach to diabetic nephropathy. Let me share to you my slides. For our learning outcomes, first, to identify the salient features and important to diagnosis of diabetic kidney disease. Second, to formulate a diagnostic plan for a patient with diabetic kidney disease. And lastly, to interpret and understand the laboratories and ancillaries for a patient with diabetic kidney disease. Diabetic kidney disease occurs in patients with diabetes mellitus and reduced kidney function that can be from many diverse causes, including hypertensive nephrosclerosis and unresolved acute kidney failure. Diabetic nephropathy, on the other hand, is a diagnosis that refers to a specific pathological and structural and functional changes seen in the kidneys of patients with diabetes both type 1 and type 2 that result from the effects of diabetes on the kidney. Its clinical presentation is characterized by persistent albuminuria and a relentless decline in glomerular filtration rate and raised arterial blood pressure and enhanced cardiovascular morbidity and mortality. Diabetic nephropathy was further subdivided into your macroalbuminuria and your microalbuminuria. Your macroalbuminuria, also known as severe albuminuria, overt nephropathy, and clinical proteinuria of greater than or equal to 300 milligram per gram. While your microalbuminuria, also known as your incipient nephropathy or moderate albuminuria, with a clinical proteinuria of 30 to 299 milligram per gram. Another subtype is your non-albuminuric diabetic kidney disease. This is among patients with type 1 diabetes with reduced eGFR of around 7 to 24%, while among patients with type 2 diabetes and reduced eGFR, it's around 39 to 52%. So to further guide us in our discussion, this is the outline of our discussion. First, the clinical epidemiology, patient history, physical examination, interpretation of laboratories and ancillaries, interpretation of urinalysis, evaluation of proteinuria, and determination of kidney function. Because not all individuals with diabetes develop all the possible complications, systemic screening for relevant complications has become a major part of the diabetes care. Approximately 20 to 40% of patients with type 1 or type 2 diabetes mellitus develop diabetic kidney disease. Diabetic kidney disease is the single most common cause of ESRD in many parts of the world, including Europe, Japan, and USA. And patients with diabetes account for 25 to 45% of all patients enrolled in ESRD programs. Less than 60% of patients overall are aware of their disease, and a prevalence of 2.6%, meaning 1.2 million adult Filipinos or more have CKD. So type 1 diabetes, there's urinary albumin excretion, usually normal at the diagnosis, while for your type 2 diabetes, it is more insidious, with poor glycemic control and elevated blood pressure may be present for several years before diagnosis, and therefore, albuminuria is frequently present. To help us understand, we have a patient with us today. So our patient is a 55-year-old man with type 2 diabetes, diagnosed 1 year ago, referred to us for evaluation of proteinuria, noted first 3 months ago. He has a family history of diabetic nephropathy, and on physical examination, his blood pressure is 140/80 with a BMI of 30 elevated, with normal fundal examination. For the laboratory studies, the serum creatinine is 1.5 milligram per DL, it's elevated, and a urinalysis with positive 3 protein and unremarkable sediments. So there's a strong genetic basis for diabetic kidney disease, both for the modifiable and the non-modifiable risk factors. So increasing age is a directly related to the prevalence of diabetic kidney disease, with decreased EGFR rising from around 8% in the fifth decade of life to 19% in the sixth decade of life and around 35% in the seventh decade of life. So for evaluation of a patient with diabetic kidney disease, a thorough history should be done. So first, you have to ask and inquire about the history and symptoms of diabetes. So you have to ask questions about the duration of the diabetes and the medications of the patient. Also, you should ask for signs and symptoms of poor control of diabetes, such as your polyphagia, polydipsia, polyuria, and nocturia. There is overwhelming evidence that glycemic control impacts the risk for incident and progressive diabetic kidney disease. Also, you have to ask for symptoms of blurring of vision and prickling sensation of the sole of the feet or paresthesia or dribbling of urine, which can be signs of diabetic retinopathy, diabetic neuropathy, or diabetic nephropathy. And now, very importantly, you have to ask a very thorough history of your renal status. So there are a gamut of questions that you should ask your patient, especially if this is the first time that you'll be seeing your patient. So first is the history of previous creatinine elevation and treatment. You have to make sure that the patient either has acute kidney injury or chronic kidney disease. Acute kidney injuries is increasingly recognized as a risk factor for your chronic kidney disease. Second is the characteristic of your patient at the onset of consult. So you have to assess if your patient is stable or if your patient manifests with signs and symptoms of uremia or end-stage renal failure. And this includes decrease in your appetite, weight loss, nausea, pruritus, decrease in appetite, abdominal pain, or changes in sensorium. Also, you have to check for the volume status of your patient. You have to ask for signs and symptoms of volume depletion that may be due to an increase in your insensible losses, such as fever, poor oral intake, diarrhea, or hypotension. Or signs of volume overload, such as difficulty of breathing, dyspnea, or presence of edema. Also, you should ask if there's changes in urine volume, if there's decrease or no urine output, which is a sign of renal failure. Also, you should ask about the urinary symptoms such as dysuria, frequency, which can be signs of your infection or inflammation, or your lower urinary tract symptoms such as hesitancy, poor or intermittent straining, dribbling, feeling of incontinence, or feeling of incomplete void. And your urologic disorders such as your nephrolithiasis or the presence of a prostate disorder, because this can be precursor for the risk of your chronic kidney disease. Also, you should ask for signs of hematuria and a history of your complementary or alternative medicine or your herbal intake. Some herbal supplements act like diuretic or contain impurities that may cause kidney irritation or damage. Also, a thorough medical history is necessary if there's intake of your non-steroidal anti-inflammatory drug or aminoglycosides or a history of IV contrast medium. These are all at risk for initiation or progression of your renal failure. And lastly, you should ask if there's any history of past hospitalization or surgeries. Next, you have to inquire about the family history, past medical history, and the current health status. So for the family history, you have to inquire for family members with diabetes, renal disease, or hypertension. Diabetes, there's familial clustering of diabetic kidney disease, and diabetic end-stage kidney disease has long been recognized. For your renal diseases, some kidney conditions may be inherited, such as your polycystic kidney disease. And CKD has a familial predisposition, as reported by McClellan et al., that indicates that a family history of kidney disease or dialysis is associated with increased incidence of your end-stage renal disease. For your past medical history, you should inquire for presence of hypertension, dyslipidemia, and other comorbidities such as atherosclerosis and congestive heart failure, which will predispose your patient for susceptibility for renal failure and progression to end-stage renal disease. For your current health and risk factors, you should inquire with regards to the eating pattern and the weight history of your patient. Obesity is a risk factor for end-stage renal disease and renal failure. And also your dietary protein intake. Excessive intake leads to proteinuria and glomerular damage. Also, you should inquire for history of physical activity and sleep behaviors, history of smoking, alcohol intake, and history of illicit drug use. So this table shows the risk factors for diabetic kidney disease, which is actually classified into three: susceptibility, initiation, and progression. So for your susceptibility factors, these are your non-modifiable factors, such as your age. For our patient, the patient is male, which is actually increased risk, race and ethnicity, and family history. For the initiation factors, these are the modifiable risk factors, your hyperglycemia and your acute kidney injury. And for your progression factors, these are also your modifiable risk factors, such as your hypertension, dietary factors, and obesity. After a thorough history, this will be followed by a thorough physical examination. So first, you have to take a complete vital signs that includes your blood pressure, your pulse rate, your respiratory rate, temperature, plus your height and weight to compute for your BMI. Also, you have to check for the integumentary system, for the skin, for signs of infection or volume overload or volume depletion. And check for the head and neck. For all patients that are diabetic, you have to check for the fundoscopic examination to check for diabetic retinopathy. Also check for the palpebral conjunctivae for possible presence of anemia and your lymphadenopathies that can be suggestive of infection. Next is your cardiopulmonary, gastrourinary, and your extremities. So you should always check for signs of target organ damage of hypertension and diabetes. So for your cardiac examination, you should check for your precordial examination, check for LV heave, your SFR if it's present, check for your JVP, and also the precordium, and if there are murmurs. And also for the pulmonary, check for symmetric chest expansion and for adventitious breath sounds. This can be signs of infection or volume overload. For the gastrourinary, you have to examine the abdomen for bruits and palpable renal masses. For the extremities, you have to check for edema, diabetic neuropathy using your monofilament test, the risk or presence of foot ulceration, or if there's decreased in your sensation, and urologic examination that will include your asterixis, muscle weakness, and neuropathy. After a thorough history and physical examination, we move on to your ancillary test. First, the most important and the cheapest is a urinalysis. So for our patient, her urinalysis showed a plus 3 protein. So what does that signify? So first, we have to check if the urinalysis can be acceptable or if the specimen is contaminated. So for our patient, this is his urinalysis. As you can see, there's only few squamous cells. Squamous cells are present as contaminations by your genital secretion. So since there's only few, our specimen is acceptable. It's not contaminated. Next, we have to check for the color. For the color, usual or normal color of the urine is yellow faint. It is usually clear also. A dark yellow urine can be a sign of concentrated urine or dehydration. For the transparency, for our patient, it's clear. So usually, if it's turbid, there can be presence of your pus, blood, or bacteria. That is suggestive of possible infection or precipitation of your crystals. For the pH, for our patients, it is 6. This reflects the degree of acidification of the urine, and usually normally varies with systemic acid-base balance. For the specific gravity, it's 1.15 for our patient. The normal is 1.003 to 1.03. So this is a convenient index of urine concentration. So it tells you the volume status of your patient. So for our patient, it is normal, so our patient is euvolemic. So when you drink a lot of fluid, your kidneys make urine with a high amount of water in it, which has a low specific gravity. For the albumin, protein is normally not found in the urine, except in episodes of fever, hard exercise, pregnancy, some diseases, especially kidney disease, which we will further discuss later. For the sugar, in patient with normal kidney function, significant glycosuria does not generally occur until the plasma glucose concentration exceeds 100 milligram per dl. So for further evaluation of your albuminuria, so an early morning spot urine collection is sufficient for screening and monitoring and is convenient for the patient. However, to take account for a wide array of intraday variability, around 30 to 40%, 2 out of 3 spot urine samples within 3 months must be elevated to confirm the diagnosis. So for the albuminuria, the normal range of albuminuria is less than 30 milligram per gram, and the abnormal range is greater than 30 milligram per gram. So for our urine dipstick in the urinalysis, trace is equivalent to less than 300 milligrams. A plus 1 is equivalent to 300 milligram, which is overt. A plus 2 is equivalent to 900 to 1,000 milligram, while A plus 3 is equal to greater than 3,000 milligram, which is actually a nephrotic range proteinuria. So for our patient, his urine protein in the urinalysis is plus 3. So it's nephrotic range proteinuria. That's the reason why we requested for a urine protein creatinine ratio, which is more of a quantitative way to measure the amount of protein in the urine. And the result for our patient is 3.5, which is nephrotic range. A serum micro test is an immunospecific dipstick for detection of low concentrations of albumin in urine. So this test is intended to be used for screening in an ambulatory setting for those who don't have protein in the urine. So this is the classification of CKD based on GFR and albuminuria categories, or the heat map from your KDIGO guidelines. So to orient you, the colors, they represent the risk for progression, morbidity, and mortality by color from best to worst. So the green, it signifies low risk, while for the yellow, it signifies moderately increased risk, and for the orange, it signifies high risk, and for the red, it signifies very high risk. So in classical diabetic nephropathy, the first clinical sign is moderately increased urine albumin excretion. So that's around 30 to 300, so that's A2. And if left untreated, microalbuminuria will gradually worsen, reaching clinical proteinuria or severely increased albuminuria. That's that's at the A3 level over 5 to 15 years. So for our patient, your patient has a plus 3 protein with a urine protein crea ratio of 3.5. So that will place your patient under the category of A3. So we have to check for another laboratory marker, which is your creatinine, to be able to complete the classification. Okay, so as we've mentioned before, one important marker is your creatinine. So based on the guidelines from the American Diabetes Association and the KDIGO guidelines, or the Kidney Disease Improving Global Outcomes, diabetic patients should undergo annual testing for kidney complications using serum creatinine-based eGFR and urine tests for abnormal levels of albumin excretion. So for our patient, his creatinine value is 1.5 milligram per dl, which is actually elevated. So in clinical practice, GFR is estimated using equations. And these equations that are available is your CKD-EPI creatinine equation, your MDRD study equation, and your Krotkov formulation. What we use in our clinical practice is your CKD-EPI. It's developed in 2009 by the Chronic Kidney Disease Epidemiology Collaboration and is the recommended method for estimating eGFR. So it estimates your glomerular filtration rate based on the serum creatinine, the age, the sex, and the race. So if we try to apply it for our patient, so for our patient, his serum crea is 1.5 milligram per DL with an age of 55 years old. Our patient is male and is Filipino. So if you try to input this on your CKD epi, which is available at your QX calculator, it's readily downloadable and it's free. The computed eGFR is 52 ml per minute. So what does this signify? First, you have to make sure first, and we have to make sure if your patient has acute kidney injury or chronic kidney disease. Because if it's chronic kidney disease, then it's irreversible. For definition, acute kidney injury is defined by your KDIGO as a serum creatinine rise by 0.3 milligram per DL from baseline within 48 hours, or a serum creatinine rise of greater than 1.5-fold from the baseline value, which is known or presumed to have occurred within 1 week, or a urine output of less than 0.5 ml per kilogram per hour for 6 consecutive hours. If the patient does not have a baseline serum creatinine within 1 week of admission or consult, it is acceptable to use a reference serum creatinine value within 3 months. Now, for your chronic kidney disease, according to your KDIGO guidelines, abnormalities of kidney structure or function present for greater than 3 months with implications for health. So for the criteria, it's either of the following present for, again, greater than 3 months. So first is your markers of kidney damage, so 1 or more. This includes your albuminuria, persistent albuminuria, your urine sediment abnormalities, electrolyte and other abnormalities due to tubular disorders, your abnormalities detected by histology, structural abnormalities detected by imaging, history of kidney transplantation, or a decreased GFR of less than 60 ml per minute. So the broader term for kidney disease in diabetes is used for patients with chronic kidney disease. Is less than 60 ml per minute regardless of the background. Okay, so going back to your heat chart, as we've said before, so we already have your albuminuria, which is A3 for our patient. So actually for your heat chart, for CKD, this is classified based on 3 things. So first is the cause, second is the GFR category, and the third is the albuminuria category. So for the cause for our patient, it's diabetic kidney disease. Now for the GFR category, it has 5 stages. And as we have computed your eGFR based on a CREA of 1.5 milligram per DL using your CKD epi, the eGFR is 55. So that will place your patient under G3A or mildly to moderately decreased. However, your patient is on A3. So that means, that will place your patient under the red block. So the red block signifies very high risk for progression, morbidity, and mortality. So other important laboratories are your blood urea nitrogen, your complete blood count, and your arterial blood gas. So for your BUN, urea in blood is elevated during kidney damage, also in episodes of dehydration. For your complete blood count, you should check for your hemoglobin, presence of anemia, because anemia can develop earlier in diabetic kidney disease than in other types of chronic kidney disease. And usually it presents as normocytic normochromic anemia. Also, you check for platelet if it's normal, and also if you have leukocytosis or leukopenia, which can be signs of infection that can also greatly affect your kidneys. And also your acidosis for your blood gas. So impaired hydrogen excretion due to decreased ability to produce ammonia is seen with worsening renal function. Other ancillaries include your potassium, your sodium, your uric acid, ionized calcium, and your inorganic phosphorus. So you have to monitor for changes not just in the blood pressure, but also in the serum creatinine and serum potassium within 2 to 4 weeks if you're going to initiate or increase the dose of your ACE and ARBs. Also, for your uric acid, elevated uric acid affect your endothelial function and contribute to worsening renal failure. And also, declining GFR leads to a systemic disorder of mineral bone disease. And these changes start to occur when the GFR falls below 60 ml per minute. So this includes abnormalities in your calcium, your phosphorus, your intact PTH, your vitamin D metabolism, and abnormalities in bone turnover, mineralization, volume, linear growth, or strength. Next is your lipid profile and your HbA1c. So for the lipid profile, hypercholesterolemia may impair the kidney's hemodynamic response, resulting in antidiuretic and antinatriuretic effects. Also, for your HbA1c, two landmark trials conducted with patients with early stage 1, DM type 1 and DM type 2, showed that intensive blood glucose control early in the course of disease exhibits a long-lasting favorable effect on the risk of diabetic kidney development. This is what we call the legacy effect. So this is actually a table from the KDIGO, or the Kidney Disease Improving Global Outcomes for the diabetes control, which is actually released just this year. So they have recommendations on the frequency of HbA1c for our CKD patients. So as we mentioned, there are 5 stages for CKD. So for those under CKD stage 1 to stage 3B, you can use your A1C, and ideally it can be used twice per year or up to 4 times per year if not achieving your target or any changes in therapy, and it's highly reliable. However, for CKD stage 4 and 5, including those who are on dialysis or on kidney transplant, it is advised to use it twice per year, up to 4 times per year, if not achieving target or change in therapy. However, the reliability is low. For the ancillary, we have your ultrasound. Sorry for that. So for the ultrasound, it's the most frequently used diagnostic examination for the evaluation of the kidneys and the urinary tract. It is non-invasive and requires minimal patient preparation. It is used as first-line examination in your azotemic patient for assessing renal size and the presence or absence of hydronephrosis or obstruction. So the normal kidney size is around 9 to 12 centimeter in length. And as you can see, the normal renal cortex or parenchyma is less echogenic than the liver and the spleen. So it's the liver parenchyma is much brighter. On the other hand, real-time imaging can be used to evaluate for your bladder wall, for tumors, stones, and a color flow Doppler, as you can see, can be used to evaluate the bladder in well-hydrated patients to identify ureteral jet, which is produced when there's peristalsis that propels urine into the bladder. So the absence of this ureteral jet can indicate total ureteral obstruction that can actually cause acute kidney injury. Another imaging is your nuclear scintigraphy, which offers imaging-based diagnostic information on renal structure and function. It is widely used to measure GFR, however, study of choice for evaluation of renal transplant and functional obstruction, because this is actually quite expensive. So while the primary purpose of kidney biopsy is actually for diagnostic purposes, it also offers usefulness in prognostication. However, it is not indicated in everyone, since unless there is actually an indication for biopsy, or if it will require a change in the treatment protocol. So the clinical indications for kidney biopsy in diabetic kidney disease are: first, nephrotic range proteinuria or kidney failure in the absence of diabetic retinopathy. Second, nephrotic range proteinuria or kidney failure with diabetes duration less than 5 years. And third, nephrotic range proteinuria with normal kidney function. Fourth, unexplained microscopic hematuria or acute kidney injury. And 5, rapidly worsening kidney function in patients with previously stable kidney function. So that actually ends my discussion. I hope you will able to learn something, and it will be helpful in evaluating your patients with diabetic kidney disease. These are my references for the lecture. Again, thank you very much.